Good morning. I welcome you all to this IC on navigating challenges, managing and mitigating complications associated with glaucoma surgery. So we will be talking about all the complications related to the major surgeries such as trabeculectomy, the tube surgeries, and including the MIGS. So with no further ado, we'll start off with the first topic. Dr. Karthikeyan will be talking about the complications related to tubes.
Good morning, everyone. First, thanks Subhash Ma'am AIOS for giving this opportunity. I'm going to talk about how to approach to the complication of glaucoma drainage devices. Okay. So coming on to complication, what and all complication we can face while using a glaucoma drainage devices? In up to 50% of the cases, 4 to 50% of the cases, we can expect hypertoning. Then in up to 16% of the cases, we can expect tube or plate erosions. Tube corneal touch and corneal decompensation can occur in 15 to 35% of the cases. Encapsulated bleb can occur in 15 to 70% of the cases. Hyphema can occur in up to 20% of the cases. Then other things like diplopia, tube lock can occur. Rarely we can see the blebitis, endophthalmitis, panophthalmitis, and even retinal detachment. So when you have hypertony, what can you do? So either you can use a valved glaucoma drainage devices like Ahmed glaucoma valve, or when you are using a non-valved glaucoma drainage devices, you can use the Ripcord ligation suture, interluminal stenting, and tube ligation sutures. And initially, and later on after 6 weeks or after 4 to 6 weeks, depending upon the IOP, we can remove those sutures, or you can plan it as a two-stage procedure. Where initially you will just implant the plate, then after 4 to 6 weeks, after the biological membrane forms around the plate, in the second procedure we can insert the tube inside the anterior chamber. This will prevent a hypertony in the early stage. So this is one of the case in which the patient had a we have entered a Ripcord ligation suture. It is operated post PK with secondary glaucoma. Here first we are identifying the Ripcord suture. Then we'll make a nick in the conjunctiva. Then after identifying the then localizing suture, we'll just take it out. So the removing the Ripcord ligation Ripcord suture is it's a very easy procedure. Just nick in the conjunctiva and just remove it. What will you do when there is a tube or plate exposure? So intraoperatively, to prevent a tube or plate exposure, we will make a partial thickness scleral flap, or we can make a scleral tunnel, and we can cover it. Use next in a mild cases of tube or plate exposure, we can do conjunctival autograft or just resuturing, as we have seen in these cases. But when this if the defect is large, then we can use the corneal or scleral patch graft. So this is one of the most commonly encountered complication, that is encapsulation of the bleb. What can we do? In early cases, we can use aqueous suppressants, C for IOP control. If IOP is not controlled, then we can try needling. Needling will just insert the 26 gauge needle and try to wipe out the capsule. If that fails, if multiple needling attempt fails, then we have to proceed with capsulectomy. See in this patient, in this video we will see how capsulectomy is done here. We will apply a traction suture and expose the area, and you have to make the incision in the conjunctiva. Then gently we will dissect the tenons and conjunctiva from the capsule. Now we can see the pearly white kind of thing, that is the capsule which has formed, which is preventing the aqueous from draining. See, as soon as we make a nick in capsule, we can see the gush of fluid coming out, and bleb height is reduced. So we have to carefully dissect and try to make remove the capsule as much as possible. See here, this is the capsule, and beneath the capsule we can see the AGV foot plate also. We'll try to remove as much as capsule as possible, so that the aqueous is diffused in some conjunctival place and going to the veins, episcleral veins. After dissecting the capsule, we can just suture it. We can close the wound with 10-0 nylon suture or a 6-0 vehicle suture. Next, what do we have is tube corneal touch. What can we do? If when there's a tube corneal touch, we can do a tube trimming, or we can even reposition the tube, remove the tube from the sclera, and again reposition in the sulcus. If the patient is having an idea or some other thing, then even in sulcus also it will be a problem. That time you can use 9-0 proline anchoring sutures. Like in the both side of the conjunctiva, we can just insert the 9-0 proline and make it and put a tube behind this proline sutures. Here is one of the cases in which a very long tube, where we did a trimming of the tube. So first we made a incision side ports in 2 places for maneuvering of the instruments. Then using the micro forceps, we just lifted the tube. See, this tube was very long, and it was going. We are not able to see the tip of the tube, and iris also can block this tube. Gently we'll have to remove the tube and hold it with the micro forceps in one hand. In another hand we have a micro scissors. Then we can cut it. While cutting, we have to make sure that we are holding the other part of the other end of the tube. Otherwise, sometimes it might fall down. We may not able to pick it up. In this case, it is okay because the iris is there and lens is there. After cutting, we have to hold in the wherever the thinnest part of the tube. Through that only we can take it out. Otherwise, we have to extend the incision. So we have to maneuver it in a way so that the smallest diameter of the tube is coming out of the wound. Okay. Next, in case of tube can be blocked using due to vitreous or blood or silicone oil. This is the case in which silicone oil was blocking the tube. Here we are using the micro MVR. We are making an incision in the tube. So we are making a vent here, and do the other part we are just flushing out with BSS. So this is a technique of intercanal vent and flush in case of a silicone oil blockade. So whenever you have diplopia, it can be due to restriction of extraocular movement after placement of the tube. In case of a large implant where we maneuver the muscle and all. So an increased height of the bleb also can cause diplopia. So for that we have to choose the correct size of the implant, and with minimal manipulation of the muscles can avoid this complication. Next, other complication like blebitis, endophthalmitis and panophthalmitis, it occurs due to improper conjunctival suturing, rubbing of the eyes leading to conjunctival dehiscence or tube plate erosions. And management includes intravitreal antibiotics, platelet planar vitrectomy, and removal of GDD in case of panabdominal. It is tailored according to the individual cases. This will be talked in detail with by my retina faculty. Okay, thank you. Before finishing off, I'll thank my alma mater and my guide for providing it me all the knowledge. Thank you.
Thanks, Dr. Karthikeyan, for covering all the complications related to tubes. So we'll move on with the next speaker. It is Dr. Shreyas, and he will be addressing the posterior segment complications of glaucoma surgery. Over to you, Shreyas.
Laser pointer. So good morning one and all. Either. So we all know that our glaucoma colleagues are always there to protect the optic nerve from the destruction of glaucoma. So, but sometimes the path of this protection can go haywire and threaten the vision. There comes the role of retina surgeon to protect the retina and to be the saviors. So finally, we all have a common goal to protect a precious thing of human life, the vision. So in my next few minutes, I'll be talking on how to address the posterior segment complications arising out of glaucoma surgery. It's not moving. So these are the broad headings under which I'll be covering this topic. Coming on to local anesthesia related complications, first of all, block related perforation. Risk factors include longer axial length, especially when associated with posterior cephaloma, use of longer needles, poor technique, uncooperative patient, and history of previous scleral buckling surgery. Patient will have intense pain and the globe can be hard or soft. There will be loss of red reflex. Management includes when the needle track is visualized, barrage laser can be done. When associated with vitreous hemorrhage or retinal detachment, a thorough vitrectomy has to be done. All the break areas should be identified. Fluid air exchange is done, and then laser barrage is given around all the entry and the exit sites. Finally, gas or silicone oil tamponade is used. Next complication, the retrobulbar hemorrhage. It can be arterial rapid onset type or venous slow onset type. Risk factor include use of longer needles, pre-existing vascular or bleeding disorders. The signs to recognize are hemorrhagic hemosis, tense orbit, and raised intraocular pressure. Clinically, on fundus examination, we can see presence of these choroidal mounds or choroidal folds, and classically on CT scan or ultrasound B scan, we can see the coning of the globe. Mild cases without intraocular pressure rise can be just observed. Rapid onset severe retrobulbar hemorrhage requires urgent attention and it can compromise retinal circulation. We have to deal with urgently in the form of giving intravenous mannitol, paracentesis, or performing lateral canthotomy. Coming on to hypotony related complications, first of all, decompression retinopathy. It refers to optic nerve and retinal changes secondary to an iatrogenic sudden decrease in IOP. Trabeculectomy is the most common cause. Other surgeries which can cause decompression retinopathy include tube surgeries, AC paracentesis, and laser PI in a patient who has very high IOP. Clinically, we can see the patient having multilayered retinal hemorrhages, white-centered hemorrhages, and the presence of macular edema and disc hyperemia or edema, and rarely it can be associated with choroidal detachment. Most cases resolve spontaneously and nothing needs to be done. Persistent vitreous hemorrhage requires partial vena vitrectomy. How to prevent this complication? We have to achieve a good control of IOP before surgery by giving patients preoperative mannitol. And intraoperatively, the IOP has to be reduced gradually. Coming on to next complication, the effusions. Risk factors include overfiltering or leaky blebs, use of perioperative antimetabolites, nanophthalmos, and diffuse choroidal hemangioma in the setting of Sturge-Weber syndrome. Clinically, they appear as smooth dome-shaped orange light brown peripheral mounds. IOP is almost always low, and on ultrasound B scan, they appear as convex immobile membranes with no submembrane echoes. Management includes stopping of all anti-glaucoma medications. Cycloplegics help to deepen the anterior chamber. Topical steroids are decreased in overfiltration and increased in inflammation. Systemic steroids are again used for controlling inflammation. We can opt for surgical measures to reduce overfiltration or leak. When is drainage indicated? It is indicated in cases of kissing choroidals, as you can see here, or intractable low IOP with flat anterior chamber. Serous retinal detachments can be very well managed with systemic or periocular steroids. This was one of our patients who developed extensive exudative detachment on first post-op day after OD implantation. This patient was managed with oral steroids and PST, and by 8 weeks the exudative detachment had resolved. Coming on to suprachoroidal hemorrhage, it occurs due to rupture of posterior ciliary vessels in the suprachoroidal space due to rapid reduction in IOP. Risk factors include high preoperative IOP, severe perioperative hypotony, aphakia, high myopia, and systemic hypertension. Clinically, they appear as smooth, dome-shaped, dark brown peripheral mounds. Patients can have pain. IOP can be low or high. Ultrasound B scan shows again convex immobile membranes with submembrane dot-like echoes. Limited detachments confined to 1 or 2 quadrants can be observed. Drainage is needed in extensive suprachoroidal hemorrhage. Ideally, the drainage is done around 7 to 10 days when the blood liquefies. Serial ultrasound will help us to decide the timing of drainage. So coming on to the techniques of choroidal detachment drainage, both scleral cut down as well as trocar assisted drainage can be done. A scleral cut down is given at around 3.5 to 4 millimeter, and with the help of AC maintainer, the effusion is drained. In case of trocar assisted drainage, all of the retina surgeons are well versed with trocar technique. So in this, the AC maintainer is placed, and then around 3.5 to 4 millimeter, a trocar is placed obliquely to enter the suprachoroidal space. So as you can see here, there is an oblique entry, and then the trocar is then manipulated to drain the blood or the effusion. So coming on to vitreoretinal complications, first of it, vitreous loss. Risk factors include pre-existing PC defect or zonular weakness, aphakia, excessive local block or valsalva by the patient. Vitreous in anterior chamber can cause corneal edema, chronic uveitis, endophthalmitis, retinal tears or detachment, cystoid macular edema, and can also lead to tube blockage. So this was one of our patient who presented with vitreous in the anterior chamber and was threatening to block the tube. This patient subsequently also developed cystoid macular edema. In this patient, we went ahead with triamcinolone assisted anterior vitrectomy. So diluted triamcinolone is injected, and then anterior vitrectomy is done to clear the vitreous from the anterior chamber as well as at the tube site. Subsequently, this patient also received intravitreal triamcinolone. So this is 2 weeks post-op. We can see that pupil is nicely round. There is no vitreous at the tube site, and the cystoid macular edema had completely resolved. Coming on to rhegmatogenous retinal detachment, risk factors include pre-existing lattices, uveitis, history of trauma, vitreous loss or pars plana tube placement without adequate vitrectomy. Pars plana vitrectomy is a procedure of choice as the conjunctiva can be spared. We have to give special consideration not to fiddle with the conjunctiva too much, as it can lead to blood leak or scarring. Pars plana tubes require special attention because silicone oil can migrate through the pars plana tubes and into subconjunctival space. The solution is that you can either ligate the tube or bring the tube into the anterior chamber through a surgical PI. This was one of our patient who developed post-penetrating keratoplasty secondary glaucoma and had a tube implantation and had a SFL as well as. So this patient, the tube was placed in the pars plana region. Subsequently, the patient developed retinal detachment with PVR changes. We went ahead with standard 3-port pars plana vitrectomy. Vitrectomy was completed and membranes were dissected. The routine steps of vitrectomy were carried out for this patient. So finally, again the vitreous was cleared from behind the IOL. We noticed that the tube was lying behind the SFIOL. The tube was then exteriorized, cut short, and then the tube was placed in the anterior chamber so as to avoid contact with the silicone oil. So this step is very crucial as it helps to prevent subconjunctival migration of the silicone oil. Subsequently, routine steps of the vitrectomy were carried out. Hypotonic maculopathy refers to retinal changes in the setting of decreased IOP. It is an indicator of persistently very low IOP. Clinical features include presence of subtle macular folds, disc edema, vascular tortuosity. Sometimes the disc edema can be very severe. And on OCT, we can see the presence of retinal thickening as well as choroidal folds. Management includes correction of factors leading to hypotony, oral or periocular steroids to control inflammation, Chronic irreversible hypotony, vitrectomy with membrane peeling and cyanocolloid injection is recommended. Coming on to the last complication, the inflammation-related complications, I'll be dealing only with bleb-related infections. The incidence is around 0.1 to 1.3% after trabeculectomy. If only the bleb area is involved, it is called as blebitis. If the infection spreads to the aqueous and the vitreous, it is known as bleb-related endophthalmitis. Risk factors include perioperative use of antifibrotic agents which lead to thin avascular leaky blebs and presence of releasable sutures, inferior blebs, tube erosion or exposure. Common organisms implicated are Streptococcus, Staphylococcus and H. influenza, and they are usually highly virulent. Blebitis responds well to intensive topical and systemic antibiotics. This was one of our patients after RD implantation developed localized infection of the tube site area. So this patient was managed very well with oral antibiotics and high strength gatifloxacin, and there was complete resolution in 2 weeks. Bleb-related endophthalmitis requires aggressive treatment. Early pars plana vitrectomy is recommended. So this was one of our patient who developed bleb-related endophthalmitis, that is tube site infection. Subsequently, this patient underwent standard three-port pars plana vitrectomy, removal of all the membranes and core vitrectomy. Subsequently, intravitreal antibiotics were given. Then important step is to give subconjunctival antibiotics also to control the infection locally. So finally, timely intervention saves vision, and we can all be superman or woman in somebody else's life to save the vision. Thank you.
Thanks, Dr. Shreyas, for that excellent presentation. So this actually presentation reiterates the importance of working in tandem with the retinal surgeon to evade some of the complications related to glaucoma surgery. So we'll go on to the next topic, preventing and managing complications of minimally invasive glaucoma surgery. So this is by Dr. Sharmila R.
Good morning, everyone. I thank Subhashini for including me in this course, and I also thank AIOS for the opportunity. So I'm going to be talking about how to prevent and manage complications following MIGS. We all know MIGS is now a very recent glaucoma surgery, which is picking up a lot, and it has served to cater all kind of glaucomas, right from mild to severe glaucomas. So why MIGS? We all know that it is a simple procedure, ab interno procedure, micro-incisional surgery, high safety profile, faster recovery and minimal trauma. Though it has a high safety profile, it does have a set of complications that one has to be aware of. So comparing the trab tube complications to the MIGS, it's very, very minimal because it doesn't have potentially blinding complications like what we saw with the previous two speakers. So how do we avoid complications following MIGS? Number one is with a good patient selection. So in order to have a good surgery outcome, a good patient selection is very, very important. Tailoring the treatment to the patient and to the type of glaucoma is also very crucial. A good detailed gonioscopic evaluation, knowledge about the angle anatomy for better visualization, and skill of the surgeon, all of this play a role in the complications. So how do we prevent complications? Number one, a detailed systemic evaluation is very, very crucial in these patients who are undergoing MIGS because it is an angle-based surgery, there's a high chance of bleeding. So you have to rule out any history of any hypertension, which is uncontrolled, patient who's having cardiac illness, who's on blood thinners, blood dyscrasias, etc. So sometimes it is important also to investigate like bleeding time, clotting time, PTT before taking the patient for surgery. Stopping blood thinners is very, very crucial. Depending upon the type of blood thinner they are using, we have to titrate, like whether it is for 3 days that we have to stop, or 5 days or a little longer. Sometimes it's also mandatory to switch to a low dose heparin whenever needed if you cannot avoid stopping the blood thinner. And you need to have a facility of adjustable OT tables, good OVDs, and use of adrenaline intraoperatively. So looking at the complications, it can be broadly classified as intraoperative and postoperative complications. The most common complication encountered is hyphema. There may be also some other subtle complications but related to the technique like DMD. There may be a false passage, there may be cyclodialysis or hydrodialysis. Postoperative complications again can be early complications or late complications. Again, postoperatively you can see a lot of patients having hyphema, retained blood clots, high intraocular pressure. Sometimes you can go for hypotony when there is cyclodialysis. Late complications like cystoid macular edema, late hypotony or persistent high intraocular pressures are also reported. So what are the risk factors for hyphema? So the type of the procedure itself. So we have procedures which include cutting of the trabecular meshwork. We have procedures which include stenting. So it could be related to the procedure itself. Then second thing is systemic history, like already what I mentioned. You have to have a good knowledge about how many days you have to stop patients from blood thinners. And younger patients, myopic patients, because of lower scleral rigidity, there is a high chance of bleeding. And also type of glaucoma that you choose to operate. Like if you use a patient, if you're going to operate on neovascular glaucoma, there may be some kind of angle neovascularization that would lead to excessive bleeding. So hyphema in mixed surgery, it basically occurs because you're creating a direct communication between the anterior chamber and the Schlemm's canal. So there's increased outflow of aqueous and sudden changes in the pressure. So the pressure in the Schlemm's canal exceeds that of the anterior chamber. So the IOP drops below episcleral venous pressure. It pulls the blood from the Schlemm's canal and the collector channels back into the anterior chamber, causing a blood reflex, which is, though it is an indicator of a successful surgery, it is a very common encounter that one would face. So this is a surgery of a mixed surgery which is with a KDB glide instrument. You can see that it is an excisional goniectomy where we just excise the TM. So you can see that profuse bleed happens like this. So intraoperatively, it's very important to control the bleeding. First, do a thorough wash, use adrenaline to control the bleeding, use an OVD and tamponade the bleeding points, wait for some time and then resume the surgery. And later, at the end of the surgery also, whenever there is a bleeding point, you can leave some viscoelastic to tamponade the blood. And this is again another surgery which is a GAD surgery being performed here. So the initial incision you make on the TM. So this is done with an MVR blade. So once we do this, again there may be some bleeding points that you see. It is important to visualize what you're seeing. So without visualization, you may not be able to proceed with the surgical steps, number one. Secondly, you may be just having a false passage, and that might also cause more of complications, like you can have iridodialysis, you can have bleeding, cyclodialysis, etc. So compared to the other surgeries like Tenito, minimally invasive glaucoma surgery, or the KDB glide, the GAT is supposed to have a lot of bleeding because you're basically creating a 360 degrees of trabeculotomy. So there may be bleeding points which occurs circumferentially, producing a profuse bleed. So managing hyphema, how do we avoid hyphema, or how do we control the bleed is intraoperatively. Number one is stop and displace the blood with OVDs. We can use adrenaline. You can just wait on the table, have some patience, and just give it some time to control the bleed. And then don't treat when you can't see. So whenever there is bleed, just don't proceed with the surgery. Just wait, clear out the bleed and see what is happening. Do a thorough AC wash. And so it's also okay to leave some viscoelastics which will act as a tamponade to control the bleeding points. Post-operatively, we need to make sure that we give a tight pad and bandage, atropine. Very importantly, we'll have to restrict any activity post-operatively. Avoid Valsalva-like maneuvers, strenuous activity, and coughing or constipation should be avoided. Sometimes we can just follow the reverse Trendelenburg position as well. So early postoperative hyphemas usually are transient. They are self-limiting and they resolve within 1 to 2 weeks. And sometimes you can use steroids to speed up the resolution of the bleed. So this is another, this is a video of a patient who had a persistent hyphema for 2 weeks after surgery, and we decided to do an AC wash. So you can see that there was an organized blood clot which I'm trying to take out, but then what is important is you can see that there is fresh bleed which is coming behind. So what happens is when we resume the blood thinners, after the surgery we resume the blood thinners. So when we resume the blood thinners, there is still a tendency for them to bleed. So that is something which we also have to keep in mind, like how we can titrate this depending upon the tendency to bleed intraoperatively. So this is again another patient who had, like, after 2 weeks after the surgery, there was an organized blood clot. So I tried removing here, and then I see that there is fresh bleeds that's coming circumferentially. So I had to again inject viscoelastic, leave some viscoelastic, and then the pressure, we have to keep the closing pressure to be very, very high to avoid re-bleed, and that may cause more of high intraocular pressures postoperatively, which we have to tackle it. So this is again a patient from Andaman who had a hyphema of 3-4 millimeters, which resolved. And then again, after the hyphema resolved, in the postoperative visit when he came after 2 weeks, there was blood behind the IOL. So this is like almost half of the visual axis is covered by blood, and he was leaving to Andaman that day, so we had to actually take him for surgery and wash this. And this was a little more challenging because there was a lot of adhesions between the capsule and the IOL. So when I took for surgery, there was a lot of synechia and adhesions. So it was a little challenging to clear out all of that and go behind the IOL to do an AC wash here. So the blood is being washed under the IOL, and it appeared like there was a fresh bleed there as well. And then again I closed it with viscoelastic, both under the IOL as well as above the in the anterior chamber. So this patient did well, and he came back last week for the other eye surgery. And he decided not to go for a combined surgery because of this experience of severe bleed here. This is a post-operative picture. So there are chances of patients, after you treat the hyphema, there is a high chance of increased intraocular pressure. Number one, because we leave some viscoelastic, there may be retained blood clots, there may be post-operative inflammation, etc. And severe inflammation, because you leave viscoelastic, that may lead to a lot of fibrin membrane like what is seen here. So although we control the bleeding, we end up with another complication like a organized membrane which is sticking to the IOL, which obscures the vision. So this is very common with excessive manipulation, surgical trauma, and a prolonged surgical time, and not using steroids properly. So this is one patient who had a DM detachment during surgery. So this will float like a small membrane, which is very important to identify at the initial stage itself. Because if you just keep washing, and this may just, a total detachment is also possible there. And this is one patient post-GAT where false passage and there was an iridodialysis. And sometimes wrong identification, you may just end up with cyclodialysis, and post-operatively the patient will have hypotony. So all of this can happen. This is one particular patient who's a JOAG patient who's an architect. He had a family history of glaucoma, so I operated on him, and then he had diffuse hyphema. So we went and washed the hyphema, and after that his pupil became fixed like this. He developed a cataract. So it was actually bothering his vision. So he came just for a surgery, and he ended up doing 3 surgeries, one AC wash, and then we also had to take up for cataract surgery following this. So there are also problems related to the device, because iStent, though I'm not using very commonly, it is still possible to get stent occlusions or migrations or displacement, which is dealt with. And reviewing the literature, that looking at the complications, the GAT complications, or any complication for that matter with any of the mix, most common complication is hyphema. Whether it is with GAT or KDB, it's mostly with hyphema. So the takeaway pearls here are choosing the right mix based on the severity of the disease. The angle status and type of glaucoma is very important. Careful gonioscopy and adequate surgical training is essential to avoid complications. Stopping blood thinners and taking adequate measures to control intraoperative bleed is important. Close post-operative monitoring is necessary to identify the complications and prompt management, especially when you have to restart them on blood thinners. I generally follow the 4P rule. Basically, practice, patience, perseverance, and prayers can all help in managing complications. Thank you for patient hearing.
Thank you, Dr. Sharmila, for highlighting the possible complications of the mixed surgeries, and it's very important to be aware of these and to manage these complications, very well highlighted in the talk. Next, we have our chief instructor, Dr. K. Subhashini, who's a professor at Jipmar Pondicherry, to talk on dealing with hypotony.
Good morning again. So I will be dealing with hypotony related to trabeculectomy. So hypotony is not a very uncommon complication of trab. So we do occur because now for all trabeculectomies we use mitomycin or 5-FU. I'm not able to go to the... I can't move on. So first let's see the definition of hypotony. There is a statistical definition as well as a clinical definition. The statistical definition is IOP less than 6 or 6.5 mm mercury or 3 standard deviations below mean. The clinical definition is any low pressure which can cause a vision drop. So the incidence ranges from 1 to 32%. In the tube versus trap study, it was seen that the hypotony complication was incidence was around 13%, and they used MMC of 0.4 milligram per ml for 4 minutes. And in the collaborative initial glaucoma treatment study, it was 9% with use of IFU. So it all depends at least partly on the technique of the MMC injection, the concentration and the duration. So when to intervene? The specific treatment to hypotony depends on the cause and the extent of the problem. So first, how do you know it's early hypotony? So hypotony which is occurring within the first 2 weeks, you call it as early hypotony, and the most common causes are bleb leak and overfiltration. Late hypotony is that occurring after 2 weeks, and the most common conditions related to late hypotony, I have hypotonous maculopathy and late bleb leak. In early hypotony, the chamber is shallow, whereas in late hypotony, the chamber most of the time is deep or normal. The mechanism of the hypotony, so most of the time it's because of increased outflow. The common reasons are overfiltration or a leaking bleb. So rarely it could be because of a cyclodialysis cleft or a ciliocoroidal detachment or egmatogenous RD. So the other mechanism is decreased aqueous production. And one thing we need to keep in mind is this patient's continuing glaucoma medications even after the glaucoma surgery. And it could also be because of a crossover effect due to the medications used in the other eye, the anti-glaucoma medications used. Then the other rare reasons are tractional ciliary body detachment and chemical toxicity to the ciliary body from the antimetabolite use. So let's see about bleb leak. So that is a very common complication that occurs following trap surgery. And so bleb leak you identify by doing the Siedel's test. So place a strip of this fluorescent over the bleb area and then see for the clearing of the fluorescent. So the because of the bleb leak, the bleb is not very well formed, so it's sort of flat, and most of the time the bleb leak is from the wound, that is at the limbal junction. Now that all of us have moved towards phonics based flap, so only, from the wound is what most of the leak occurs. Very rarely it could be because of a conjunctival buttonhole, that is because of mishandling using the toothed forceps. Sometimes you can see on the right side picture the arrow mark showing a suture protruding through the conjunctiva. This happens if your scleral flap sutures are not buried, and this can also result in a leak. So how do you manage bleb leak? Bleb leak depends. It depends upon the size of the defect, whether there's an active egress or a slow one. So if it is a small leak, you can just observe for some time, and during that period it's a good idea to use bandage contact lenses, and you call the patient after 5 days, remove the contact lens and see if the leak is sealed. So but if there is an active leak and from the wound and the chamber is very shallow and the pressures are very low, then in that case you need to take the patient to the operation theatre and resuture the conjunctiva. The other common complication is overfiltration. In overfiltration, you get a nice large bleb, but the Siedel's would be negative, and the chamber would be shallow, and the pressure is low. So the most common reason for overfiltration is loose scleral flap sutures. So if you haven't sutured well, it's not on the tighter side, then where this complication is likely to occur. So sometimes people tend to use viscoelastic to form the chamber. So and when the viscoelastic disappears over the next 24 hours, then the chamber shallows and you realize that the scleral flap sutures are loose. So the other reason is when the pressures are slowly building up, when they are 21, 22, then you tend to, you think you can do a suture lysis, or if a releasable suture was put, then you would want to remove the suture. So in that situation, so if you do it too early on the second or the third day, or sometimes it can even occur after a week too. So what happens, once you release the suture or you do the suture lysis, the pressures become very low and the bleb starts overfiltering, and the chamber also becomes shallow. So how do you manage overfiltration? You can observe for some time by giving atropine eye ointment and see for the for the pressures to slowly build up. You can even reduce topical steroids to hasten the healing process, or viscoelastic injection into the antechamber. This can be done as office procedure or in the operation theatre. Surgically, you will have to think of suturing the scleral flap if in spite of all these conservative measures, the pressures are still low and the chamber flattens. So this is one way of dealing with overfiltering blebs. The Palmberg's compression sutures. You can take suture bites through the conjunctiva and reduce the height of the bleb and reduce the aqueous outflow. There's also another method of transconjunctival suturing, when you can pass the suture through the conjunctiva and then through the scleral flap. The scleral flap sutures are loose, and then again back through the conjunctiva. This also helps in instead of directly opening up the conjunctiva and then suturing the flap. This is also a very good technique of managing the overfiltering bleb. Then serous choroidal detachment occurs following these complications, bleb leak and overfiltration. And you don't have to panic when you see choroidal detachment. So it's not vision threatening. So temporarily it can cause a decrease in vision. Very important, you need to differentiate choroidal effusion from suprachoroidal hemorrhage, which is more dangerous. Then there are certain, sometimes you do a good surgery in spite of that serous choroidal detachment occurs. The risk factors are hypertension, older age, prior vitrectomized eyes, an anophthalmos, and then elevated episcleral venous pressure as seen with Sturge-Weber's and other related conditions. How do you manage choroidal detachment? Most of the time it's self-limited, so you can just continue the topical steroids and atropine ointment, oral steroids if there is persistent inflammation. But if the chamber is not forming at all, you can use even a heavy viscoelastic as an office-based procedure or in the operation theatre and keep the chamber formed, and then the choroidal detachment would settle down. But then you might have to consider the surgical intervention of choroidal drainage, and in which what are the indications for choroidal drainage? If it's a flat AC with lenticular corneal touch or the IOL corneal touch, and then kissing choroidals are there, and if the hypotony is prolonged, more than a week of hypotony, and the chamber is remaining shallow, IOP is very low, then you can consider. So this is a fundus picture and the ultrasound picture showing the kissing choroidals. So then this is the technique by which you can do a choroidal drainage. So do a paracentesis, form the antechamber with viscoelastic. I've chosen the infratemporal quadrant and make a conjunctival incision, and then a radial cut which starts 3 mm from the limbus, and little longer one, and then hold the lips of the scleral incision, enlarge the zoom in, and then hold the lips, and then try to slowly reach the suprachoroidal space. So if you're not confident, you can leave it to the retinal surgeon to do this. So, and then you can leave the wound open, just suture the conjunctiva with Vicryl. Late hypotony is main thing is hypotenuse maculopathy. The chamber is very well formed, but the pressures are low, and late hypotony is when hypotony occurs after 2 weeks. It's more serious than early hypotony and usually secondary to an ischemic avascular thin bleb or overfiltration of the bleb. The prognosis depends upon its duration. So if you just leave it like that and then wait for it to settle on its own, it can even result in permanent vision drop and irreversible because of irreversible chorioretinal fibrosis. So you should know when to intervene. The clinical picture of hypotenuse maculopathy is like this: deep AC, IOP that is low enough to cause the vision loss, and on fundus you see the chorioretinal folds, optic nerve edema, and vascular tortuosity. The risk factors are young age, myopia, increased CCT, and male gender. So management is you can observe. So if it's overfiltering bleb, you can use compression sutures. Autologous blood has been tried, but the definitive way of managing is by placing a scleral patch graft, and this really works well. And this is a case where we placed a scleral patch graft, and then the very next day the patient regained good vision. So yeah, place a flap, suture it with Vicryl 7O, and then suture back the conjunctiva. Late onset bleb leak, it's mainly because of due to the avascular bleb, and so here you can do an excision of the bleb and advancement of the surrounding conjunctival healthy conjunctiva. So if it's a melted scleral flap, then you can put a scleral patch graft and then advance the conjunctiva. This is you can see here the late bleb leak, the avascular bleb. So now you are making a conjunctival dissection around the avascular bleb and peeling off. You don't have to excise the full avascular bleb, just the epithelial layer can be just taken out so that it's still functional. And then you can advance the conjunctiva and suture it snug. And if you see now, there is, if you do the sedals, there is no leak. So you can put a mat with sutures, there is no leak. So prevention is always better than cure. So management tips to prevent hypotony. So you need to err on the side of the tighter sutures because you're using mitomycin in all the cases. Try leaving a of conjunctiva at the limbus so that your closure becomes snug and nice and there's less chances of leak. If there is any potential problem, you increase the post-op visits. And all of you need to remember that not all hypotenuse eyes require intervention. So early hypotony, conservative management is the way to go. Late hypotony, intervention may be required. But all of you should remember that leaving post-operative hypotony untreated can result in permanent visual damage. So be on the lookout. Thank you.
Thank you, Dr. Subhashini, for a very comprehensive talk on managing hypotony. Next, I call upon my friend Dr. Kavita, who heads the glaucoma department in Pondicherry, to give a talk on rescuing a failing bleb.
Good morning, everyone. I would like to thank AIOC and Dr. Subhashini, our chief instructor, for having me. So let's see, like, how should we deal with the failing bleb? Slides are not moving. So as we all know, trabeculectomy, doing a good trabeculectomy is just the 50% of the job done, and the mic is also on. It's on. Okay. So it's just the 50% of the job done, and the rest of the process is like achieving a successful trabeculectomy depends much on the post-operative management. It is often called as an art rather than a science. Hence, it is very important to plan a meticulous follow-up for getting a successful bleb. So what are all the features of a successful bleb? So it will be quiet and it will be like diffuse, elevated, and it will not be totally avascular. There will be paucity of the vessels, and of course we'll have an appropriate IOP control. So wound healing is definitely, it's a challenging process here. When there is excessive healing, there is a closure of the filter, and when there is like incomplete healing, as highlighted by Dr. Subhashini, we'll be having complications associated with the hypotony and the flat AC, which is also vision threatening. So it is very important to have a good follow-up protocol. Unlike cataract surgeries, where we do the surgery, send the patient and see them after 3 weeks or a month or so, here it is very important to plan a meticulous follow-up. The first visit should be on the post-operative day 1 and then see bi-weekly. When you see the patient like 15 days after the first the post-operative visit, we have to assess the bleb morphology and decide on further follow-up visits. If the IOP is adequately controlled at the end of second month, we need to insist the patient that they should not think that they have undergone a surgery and some of the patients will think that that's secure and they will stop following up. And as we saw highlighted by my previous speakers, there can be late complications related to the bleb, and hence it is very important to educate them the need for post-operative follow-up even after like months together after a trabeculectomy to prevent late complications. So how should we identify a failing bleb? So it can be either a flat bleb with this highly vascularized with a thickened surface, and sometimes it can be highly dome shaped and angry looking blebs which is localized, which is tenon cyst. So the framework for the classification of this failing blebs, it can be based on the intraocular pressure and also based on the bleb morphology. It based on the intraocular pressure, it can be a high and also it can be a low pressure also. So the low pressure is already been dealt by Dr. Subhashini, and based on the bleb morphology, again it can be either a flat or a low bleb, or it can be a high bleb. So this is an example. This shows the ring of steel, which was more common when people were doing a limbal based flap and conjunctival flap. Now it is like less common, as most of us we have moved to a fornix based conjunctival flap. So the most common reasons for the external or the failure include the subconjunctival or the episcleral fibrosis. There can be the subscleral fibrosis, or it can be just tight scleral flap sutures. And the internal causes can be the ostium can be blocked either by the vitreous or by a fibrin membrane because of the inflammation, and sometimes we can see the iris getting picked up and blocking the ostium whatever we created. Here we can see is an encapsulated bleb or tenon cyst, which is like a highly dome shaped, elevated and no angry looking blebs. How should we approach? So it's very important to intensify the dose of the corticosteroids, the topical steroids, whatever we do, and then we should try doing a digital massage, consider a suturolysis, consider subconjunctival injections of the antimetabolites, and last, if it is nothing is helping, we can consider a bleb needling. So unlike the cataract surgeries where we routinely give steroids only for a couple of weeks or 3 weeks or 4 weeks, here it's like usually it is given up to 2 to 3 months depending upon like your own post-operative protocol, because it decreases the wound healing and and reduces the chances of scarring, and it helps us to maintain the fistula whatever we created during trabeculectomy to remain open. So most of the time it is used up to the period of 3 months. So it's very important to assess the cause of the trabeculectomy failure when the pressure is high, when the chamber is also formed. Here we can see typically the iris is peeking up, and you can see the iris blocking the ostium whatever we have created. So it's very important to do a gentle gonioscopy to fix the cause. And the next is very important and very useful tip is to do an ocular massage, digital massage. It can be done either through the lower lid or it can be done through the upper lid. When we do through the upper lid, we should make sure we are doing much beyond or behind the flap area, so that the pressure whatever we are giving, it will push open, the aqueous will push open the scleral flap and the bleb will form. So we have to remember the initial conjunctival apposition after the trabeculectomy, it has to be really watertight. Unless until the aqueous gets collected in the subconjunctival space, the adhesions will start forming and the episcleral or the subconjunctival fibrosis will happen, which is the most important cause of bleb failure. So when we do the digital massage, we can very well see that it induces the aqueous to get collected in the subconjunctival space, and hence it prevents the failure. So this is a small video demonstrating the digital massage. You can see there is a flat bleb. As I just pressed behind the scleral flap, you can see the bleb is getting beautifully elevated. The next, if it is not helping, then we can think of suturolysis, and the suturolysis we have to remember when we have multiple sutures, it's very important to avoid lysing all the sutures at a time, not more than one suture at a time. And if you have 3 sutures, you can think of like select the suture based on the bleb elevation with the digital massage. Wherever you feel like the aqueous is not percolating, the suture is tight, like you can release that suture. Hoskins lens can be used, and the energy settings are shown here. And when we use mitomycin, which is of course a routine by most of us, it is very important to delay the suturolysis at least for 2 to 3 weeks. This is how intact suture looks like, and this is how you can see a space here. The lysed suture will look like. So, in case when preoperatively we know that like a young patient or a traumatic glaucoma or a juvenile glaucoma, where a patient will have a thick Tenon's tissue or inflamed eye, where there is, or otherwise if you don't have access to laser, we can think of using a releasable suture. We can see here on the video, it was demonstrating how the suture was removed, and after the suture removal, just again try the gentle massage, the blood will rise, and we can consider giving injections of 5-fluorouracil. Now people have totally shifted to mitomycin C injections, either with or without blood needling. But in my experience, I don't give mitomycin C injections without blood needling. But this 5-FU is like, though less potent, can be safely injected in case like if you are not successful with suturolysis. And the last resort is like blood needling. Before we say that we are done with the things, here we can see a small localized and highly vascularized bleb. Here we can use 25 or 26 gauge needle, and some people might use MBR blade also. So just putting a drop of no adrenaline, like cotton tipped applicator, can be applied over the area. A corneal traction suture is applied like for a better visualization. I'm using a 26 gauge needle and bending it, and we have to enter much away from the area of the bleb, and we have to make sure we keep the bevel up, and just small sweeping motions. And as we keep advancing, we can see here like as we keep advancing, like at some point of time we can see the bleb will get elevated, and it's very important not to enter directly over the area of the flap, or otherwise like we will create a leaky bleb that is like more painful than that. At the conclusion of the procedure, we can give either injections of the 5-fluorouracil, or we can even give the injections of mitomycin C, and we have to make sure we are giving much away from the bleb, 180-degree away from the bleb, because if you inject like closer to the bleb, there is a chances of the drug getting entering into the anterior chamber, and we will land up in bad complications. This is whatever I am demonstrating here is so we can see here now bleb is like beautifully getting elevated here. So this is the procedure for at the end of the procedure, definitely the eyeball will be soft, and we have to make sure that we follow up the patients post-operatively. And no, there are factors which are showing like the first post-operative day IOP is like a big determinant of the success of the bleb needling, and also the blebs which have been functioning for some time when you do needling, so the chances of success are higher than a bleb which has never functioned. And there are articles which have shown that MMC is like more potent than a 5-fluorouracil for these procedures. And this is a paper from one of our Arvind branches, like where they have evaluated the outcomes of bleb needling in a prospective way. And here, as you can see, they have given injections of 0.2 milligram per ml of MMC. The complete success in these patients who had either a TRAB or a combined surgery was 37.9%, and the qualified success was 53%. And of course, in this paper, younger age was a risk factor. So when to stop? So we need to know when to stop. It's, as I said, it's just the beginning of a whole process. It aims to achieve satisfactory bleb morphology. It really takes sometimes months together. Despite close monitoring and no often intensive follow-up and treatment and intervention, some blebs or trabeculectomy is destined to fail. And further interventions like available include it as a medication or the revision of the TRAB or a GDD or a diode. And now we have the options of considering mix in this eyes also. And this is an article where we have discussed about the wound modulation in the glaucoma surgery and the role of anti-scarring agents, which discusses about the role of antimetabolites in all the available glaucoma surgeries. Thanks for the opportunity.
Thank you, Dr. Kavita. Thanks for those excellent tips in managing a failing bleb. So now what, in spite of these measures, the bleb fails? So that is what Dr. Geeta Behra is going to speak about. Failed TRAB, what next?
No, this one. No, the last one. Thank you all. Thank you, Dr. Subhashini, Dr. Kavita, and others. So I'm going to now speak on what happens when you are at the end. You know, the TRAB is failed. So what do you do next? So we have to explore alternative treatment options here. So what is failure? Trabeclectomy failure is defined as inadequate IOP control, persistent hypotony, requiring further glaucoma surgery, and loss of light perception vision. The IOP criteria failure is defined as persistent hypotony, that is IOP less than or equal to 5 mmHg, IOP more than 21 mmHg, and IOP not reduced by 20% below baseline. So, TRAB can fail for many reasons, and understanding failure mechanisms helps in selecting treatments. So, how common is TRAB failure? It ranges from 10 to 50%, varying with risk factors, and the high risk in this category are a young age, repeat surgery, inflammatory glaucomas, and long-term success depends on follow-up care. So what are the consequences of a failed TRAB? You have persistently high IOPs leading to glaucoma progression. You have worsening visual fields and dependency on medications which reduce the quality of life, and there is a potential need for additional surgery. So why does a TRAB fail? Early failure may be attributed to hypotony, blood clots, leaks and infections. Late failure may be due to exaggerated healing response, that is fibrosis and scarring that block the drainage. And of course, the immune response plays a role in excessive healing, particularly in inflammatory glaucomas and in young patients. How do you recognize TRAB failure? You have increased IOP, poor drainage, that is a flat or an encapsulated bleb, which you can see on your right side. It's a totally vascularized flat bleb. And of course, the patients may be symptomatic. If the pressures are really high, they may have blurred vision, discomfort, pain and redness. What are the non-surgical treatment options? You have AGMs. You can try all of the AGMs depending on the situation, but maybe we can cut back on the PG analogs if there is ongoing inflammation. Laser therapy, SLT, particularly in open angle glaucoma cases, may be tried, and a combination of both AGMs and laser therapy can be tried. That would be called a qualified success if it works. But more importantly, ensuring compliance and regular monitoring visits are very important, as failure tends to be progressive. Surgical treatment. So we have rescue surgery, that is bleb needling, or a TRAB revision. Again, both the bleb needling procedures have a limited success beyond 3 months post-operative. So better to go in for a bleb needling as soon as possible. They will require an antifibrotic injection, as Dr. Kavita just showed. Or one can reopen the TRAB site and remove the episcleral fibrotic tissue and do it. But again, beyond 6 months, these things don't work. So the alternate surgeries here are a repeat TRAB, a GDD, a MIGS, cyclodestructive procedures, particularly in patients with poor visual potential, and subcyclo procedures, but they tend to be less efficacious because that would just act like one AGM. So choosing the right surgery. The severity of glaucoma determines the approach. So aggressive management is warranted in severe disease, and caution in younger patients and those with inflammatory conditions. The type of glaucoma. If it's an open angle glaucoma, one may try angle-based procedures if not done earlier. Secondary glaucomas tend to be severe and refractory, so GDDs may be better. Previous surgical history limits options oftentimes. So for example, there's extensive conjunctival scarring, and previous surgeries have gone all around the conjunctiva, then the only options left would be a GDD or a cyclodestructive procedure. And patient-specific factors like age, adherence, risk tolerance. Now these are things we have to discuss with the patient before we counsel them for the next step. When to attempt another TRAB? TRAB is the most common choice of second surgery. So it has to be considered, must be considered if we have viable conjunctiva that is untouched by any previous surgery. And if there are alternative surgical locations at the limbus. There is a lower success rate than the initial surgery, and use of antimetabolites, that is mitomycin C injections and releasable sutures, will definitely enhance the success. Close post-op monitoring here is very essential. You may have to see them on a weekly basis. And in certain situations, it may be the only options. For example, infants at a very young age, you may not have the choices. You may not have too many choices there. Glaucoma drainage devices, again, is the most common choice in recalcitrants and refractory cases. So you have in patients with extensive scarring, fibrosis, where you cannot do a TRAB, like in this case. For example, already have more than 2 failed trabeculectomies, you have secondary inflammatory glaucoma, then just go in and put in a tube. So the AGV is a flow restricting device. It reduces early hypotony, but the RD or Barwell, which has a larger plate, gives better long-term IOP control. Minimally invasive glaucoma surgeries, again, it may be effective in mild to moderate glaucoma. There aren't too many people who do it. So the iStent and Hydrus, there are some case reports. It may enhance trabecular flow, but GAT has been reported to be successful in at least 3 studies in the short term. That is at 1 to 2 years. These studies have shown to be, the GAT has been shown to be successful even following the trab. Cyclodisectory procedures are for refractory glaucoma cases, particularly in patients with poor visual prognosis. Cyclophotocoagulation, the CPC, laser reduces the aqueous production. Cyclocryotherapy is freezing, but again, this tends to have more complications, so better to do cyclocryo only for very poor visual prognosis cases. And subcyclorazors may be considered in patients with good visual prognosis, and the effectiveness is that of just 1 AGM. And this is again a failed trial in an infant where we are doing a subcyclo procedure. So how do you ensure successful outcomes? Frequent IOP monitoring, so much closer post-op visits in second procedures. Managing post-operative inflammation, so greater frequency and duration of steroids. So you need to give the steroids much more frequently than you would ordinarily after a primary trab, and you must continue it longer. Most people will continue it for at least 3 months to 4 months. And oral steroids may also be needed in post-peak keratoplasty or post-uveitis patients. Early rescue in case of failure is important to recognize early failure. Hence, the weekly visits may be warranted here. Suture lysis, antimetabolites, blebrusion, the whole package, everything may be tried in these patients. And patient compliance here hence becomes very important. So it's very important to explain to the patient that strict adherence to medication and a follow-up routine is extremely essential. So routine eye exams every 3 to 6 months, monitoring visual field progressions and adapting treatments as needed. Future directions, new drugs targeting fibrosis are on the anvil. There is gene therapy and stem cell therapy, again at very nascent stages. And these are just 2 case studies. One is the successful management with the repeat trab. So in this case, we had done a third trabeculectomy over a period of 10 years, and it still worked. So you may not give up. So many senior people who do trab for many years, they also would say, yes, you can do. And then the second case is that of a GDD placement in a high-risk patient. Here again, there's so much fibrosis. There is absolutely no occasion here to do a second trab, so it's better to go for a GDD. So the lesson here is the importance of individual care. So key takeaways, trab failure is not the end. Various surgical and non-surgical options exist, and personalized approaches ensure better outcomes. Thank you for your attention.
Thanks, Dr. Geeta, for finishing well ahead of time. So we have come to the end of the session, and we can take up questions, if any, from the floor. So we have time of another 7 minutes. Any questions from the audience? Yeah, come over the mic. And just turn it. I think it's on.
Ma'am, at which site we should prefer doing the trabeculectomy?
The retrab.
Yes.
So it is always recommended when you do the trab initially to avoid touching the 12 o'clock position. So you can either do the first trab nasally or temporally, so you have more conjunctiva left. So if you have done a trab nasally, say in the first instance, you can go temporally. Or if you have done a slightly temporal trab, you can go nasally. But it is preferable to stick to the superior conjunctiva. If you have no superior conjunctiva, very, very, very extreme situations, I have seen only experts do that. They do an inferior trab, but they will do it either inferonasally, and that may work for some time, but as I said, that's a very extreme situation, and it has to be preferably done by an expert.
Yes, now there are better options. So better to avoid an inferior trab because of the high chances for infection.
But once the trab is failed, so secondary surgery we have to prefer trab only, or we can?
No, as I said, see if you, whatever can be done for the patient. Like you saw the 2 case studies I showed you. In one case, we have done a third trab as well because there was conjunctiva. Fortunately, we had conjunctiva there. We did the third surgery and that worked, and the patient is doing well. But in the another case I showed, there's absolutely no conjunctiva. So there is no option of doing even one trab. Sometimes you just have to go straight away with GDD in some cases. So
that third trab you did in the superior
conjunctiva. If you see I'm sorry I can't show you the picture again, but you see there are 3 PIs there. It was done. But again, that's That's just that it was a late failure and there was untouched conjunctiva there, so the trap worked. But that is not recommended. You might go for a GDD the third time instead of a third trap. Only in very extreme one-eyed patients you don't want to take a chance. Yeah.
There are more chances of failure with the second or the third trap. So you see for the conjunctival mobility how it is, and then decide which site you would want to do the second trap.
Thank you.
Thank you. Yeah, please come.
Ma'am, if post-trap we get an insisted bleb, so how early we should intervene and go for needling?
As soon as possible, particularly if the IOP is high.
Yeah.
We should not wait for conservative.
You can try. There are articles which describe no aqueous suppression in these eyes, especially when the bleb is getting localized. It means like the aqueous is getting collected over there, and you can just put them on aqueous suppressants and observe for a couple of weeks. But if the intraocular pressure is getting elevated, these encysted blebs, like unlike the vascular flat blebs, you can even try a needling in the OPD itself, but you make sure like suddenly you will get a flat chamber. You should have your assistant, the pad and bandage, everything ready like before you start the procedure. Make sure you explain the patient, make sure you have the caregiver by the side and discuss. No, here also you have to take a consent. So you can try the initial aqueous suppression, and if it is not helping, you can go for a bleb needling.
Yeah, typically the encysted bleb occurs a month after. Nice, the pressures are well controlled, you feel so happy. Then slowly the bleb
4 to
encysts.
6
Yeah,
weeks
but yes, 4 to 6 weeks the bleb gets encysted. So for this, actually needling is one of the best techniques for encysted blebs. It works well. So no needling otherwise will not work in other cases, but encysted bleb it works well. So conservatively, if you want to try, you can just use the aqueous suppressants for that period of time. And then once the bleb, you can visualize if it's somewhat becoming, the height is reducing, then and the pressures are better, then you can just stop the anti-glaucoma medication.
Thank you.
Yes, I thank all my co-instructors, Dr. Sharmila, Senior Glaucoma Consultant from Arvind Eye, Madurai, Dr. Kavita, Head of the Glaucoma Unit at Arvind, Pondicherry, Dr. Geeta Bera, Dr. Shreyas and Dr. Karthikeyan and myself, we are all faculty from JIPMER, Pondicherry. Thank you to the audience for your patient listening.